Hello, and welcome to this webinar on ATSDR's EPC guidance for discrete sampling. My name is Rebecca DeVries, and I'm an environmental health scientist with Eastern Research Group. Today, I will introduce guidance developed by the Agency for Toxic Substances and Disease Registry, or ATSDR, on how to calculate exposure point concentrations, or EPCs, with discrete sampling data. Joining me today is Dr. Tanya Burke, from the Associate Director of Science Office in ATSDR's Office of Community Health Hazard Assessment, and Dr. David Millard, Associate Director of Science with the Office of Capacity Development and Applied Prevention Science. During this webinar, I will present a series of slides describing ATSDR's guidance for determining the EPC for each contaminant in an exposure unit. I will introduce ATSDR's EPC guidance for discrete sampling, provide general background information on EPCs, explain the statistics used to calculate EPCs, describe how to select appropriate EPCs for acute, intermediate, and chronic exposures, and show how to calculate 95% upper confidence limits on the mean, or 95 UCLs, when that is the appropriate statistic. To begin, I will provide a brief overview of ATSDR's EPC guidance for discrete sampling. As you know, health assessors perform many activities during the public health assessment, or PHA process. Some of these include developing a site conceptual model, screening environmental data against health-based comparison values, identifying exposure units, estimating EPCs, and calculating doses or air exposure levels. As you also probably know, ATSDR has developed tools to help with some of these activities, such as the Public Health Site Assessment Tool, or FAST, the Shower Model, and the EPC tool, a tool that automates the process for calculating EPCs as described in this webinar. ATSDR has also developed guidance to assist with the PHA process. One example is ATSDR's web-based Public Health Assessment Guidance Manual, or FAGM, which describes methods and resources for evaluating environmental exposures. FAGM is available at https://www.atsdr.cdc.gov/PHA-guidance/. ATSDR has also developed guidance documents specific to calculating EPCs, covering different sample designs and specific chemical classes. These include the agency's EPC guidance for discrete sampling, EPC guidance for non-discrete sampling, guidance for calculating benzoapyrene equivalents for cancer evaluations of polycyclic aromatic hydrocarbons, or PAHs, and toxic equivalence guidance for dioxin and dioxin-like compounds. Today, we will focus on the EPC guidance for discrete sampling. The EPC guidance document is available on the resources page within the FAGM website. If you go to the URL that I previously provided for FAGM, navigate to the resources page, and then scroll down, you will find a PDF of this guidance document. You'll also find copies of the other guidance documents that I just mentioned on this same page. The EPC guidance was developed to outline the agency's preferred approach for estimating EPCs for environmental data generated by discrete sampling methods. An EPC is a representative contaminant concentration within an exposure unit to which people are exposed for acute, intermediate, or chronic durations. A discrete sample is an individual environmental sample collected from a given point in time that's independent of other samples. Please note that this guidance is only applicable when estimating EPCs with discrete sampling data. Different approaches are used for non-discrete sampling data, such as that collected through composite sampling or incremental sampling methodology, in which multiple samples are collected and then combined into one sample for analysis. The guidance covers two main topics. First, the guidance covers how to select the most appropriate EPC statistic to use when evaluating acute, intermediate, and chronic exposures with discrete sampling data. Second, the guidance outlines how to calculate 95 UCLs when sufficient data are available for doing so, and when that is the appropriate statistic for the dataset being evaluated. Importantly, there are several topics that are not covered by this guidance. First, and as I mentioned earlier, this guidance is not applicable when working with non-discrete sampling data, such as composite samples or samples collected using incremental methodology. Second, the guidance should not be used when working with dependent data or data collected in a non-random manner. This includes instances where the results of one sample at least partially predict the results of another, such as in the case of repeated samples collected in close proximity or repeated samples collected from the same location over a short period of time. Finally, the guidance should not be used to evaluate samples analyzed for certain contaminants. These include dioxin and dioxin-like compounds, PAHs, lead, and asbestos. ATSDR has preferred approaches for these contaminants that differ from what's presented in this guidance. Of note and relevant to this presentation, you can still use ATSDR's EPC tool to calculate an EPC for dioxin and PAHs. It's just the methods are slightly different. We'll talk more about that later in this presentation. Now that we have a sense of what's covered in the guidance, let's continue with some general background information on EPCs. Again, EPCs are broadly defined as contaminant concentrations for an environmental medium, such as air, water, soil, sediment, or biota, that best represent what people are or could potentially be exposed to. They're typically informed by environmental sampling results. They can also be based on modeled results, but for the purposes of this webinar, we're going to focus on measured environmental data. EPCs are calculated for each unique and relevant exposure pathway, duration, and exposure unit. When we talk about exposure pathways, we're referring to each completed or potential exposure pathway with environmental contaminant levels above ATSDR comparison values. For exposure duration, we're referring to acute, intermediate, and chronic durations. For exposure units, we're referring to each unique geographic defined point or area where a person might come into contact with the contaminated medium. Importantly, ATSDR has developed separate guidance on how to define and select appropriate data for evaluating an exposure unit. You can find a copy of this guidance on the resources page within the FAGM website. However, since this topic is so tightly linked to estimating EPCs, I'll provide a quick refresher on some key points before moving forward. First, exposure units vary by size. For example, an exposure unit could be as small as a single drinking water tap served by a private well, or as large as a wildlife management zone where hunters have open access. Second, exposure units vary by conditions of exposure. For example, if you were defining exposure units for a home with a large half-acre lot with surface soil contamination, the entire lot may be the appropriate exposure unit for evaluating chronic exposures, while only a subset of the lot, such as the area of a small garden or a play area, may be appropriate for acute exposures. Next, exposure units are defined by people's activities and not by available sampling data. You need to consider things like how a person's assumed daily routines, preferences, and cultural practices affect their exposure, and whether any natural or physical barriers exist that might limit their access to certain areas, and not by where environmental samples were collected. Also, it's possible that a single site may have multiple exposure units. For instance, a site with a highly localized spill may have a single exposure unit. A site with a neighborhood-wide surface soil contamination, on the other hand, may have multiple exposure units, perhaps represented by each residential yard or plot within the neighborhood. For more information on this topic, refer to ATSDR's exposure unit guidance. Now returning to EPCs. I've mentioned this several times now, but once again, EPCs are calculated values that represent contaminant concentrations that people are or could be exposed to within an exposure unit. They're not directly measured. Instead, they are calculated using available environmental sampling data collected from specific locations and at specific times. How well an EPC actually represents exposures for a given exposure unit or pathway is tightly linked to how much data are available and how variable the levels of contamination are in those data. This has to do with sample size and variability. If you only have a few samples to characterize exposure, your EPC may not accurately represent true exposure. Similarly, if there is a lot of variability in contaminant levels, that is, a wide range of measured concentrations, your EPC may also not reflect exposures very well. Given that we can't possibly characterize contamination levels at every single location or every point in time for a given exposure unit, what can we do to obtain a reasonable estimate of exposure? We can use statistics. In fact, there are various robust statistical procedures available that account for uncertainties associated with environmental sampling data, including sample size and variability. And these procedures allow us to estimate reasonable yet health-protective EPCs. We do so by selecting either the maximum detected concentration or by calculating the 95 UCL of the mean. Whether it's more appropriate to use the maximum detected concentration or the 95 UCL depends largely on the dataset and the contaminants you have, such as the number of samples, the presence of non-detect observations, and sometimes the toxicity of the chemical. If the appropriate EPC is selected and then calculated correctly, the resulting value offers important insight into human exposures. Now that we've covered some general background information on EPCs, I'll introduce some important and related statistical concepts. Before we begin, I would like to assure you that you do not need to be a statistician to estimate and understand EPCs, and that includes those that are based on 95 UCLs. Let's start by considering a hypothetical scenario. Imagine a soccer field where parents are concerned about the past use of an herbicide for weed control. To investigate this concern, you need a good estimate of the herbicide concentration that children are exposed to throughout the soccer field. You can't go out and collect every particle of soil across the entire field to obtain an estimate of true exposure. Instead, you can collect samples that represent the entire area and then use results from those samples to approximate true exposures. In this example, let's pretend that 10 surface soil samples were collected at random locations across the field and analyzed for a glyphosate-containing herbicide. Based on laboratory results, you have determined that the average concentration from those samples is 25 parts per billion, or ppb. Ask yourself if you would use this average to represent exposures in your health evaluation. If so, how confident are you in this average? That is to say, do you think 25 ppb reflects the true average concentration that children are exposed to while playing in the field? Could the true average be higher or lower? It's easy to conclude that some uncertainty exists around this question. Now imagine that you have two sets of samples from the same field. One was collected by a contractor for the EPA and the other by a contractor for the county park system that owns the field. Both use the same sample collection and analysis methods, yet almost inevitably result in different sample averages. One sample configuration resulted in an average concentration of 25 ppb, while the other resulted in 62 ppb. How can this be? Which one is correct? Unfortunately, we don't know, and this is due to what we refer to as sampling error or sampling variability. When you collect discrete environmental samples in the field, those samples only represent a subset of the entire population or area that you are investigating. If you were to go out and resample the same area again and again using the same methods, you would undoubtedly end up with different mean results each time, simply due to chance. Those differences will be larger when you have fewer samples or when there is greater variability in contamination across an area. Importantly, sampling error reflects the difference between an individual sample and the larger population or area that it came from. The error part of this doesn't mean that a mistake was made in your sampling. Instead, it arises due to natural variation that occurs when a sample, rather than an entire area or population, is surveyed. It is unavoidable and will always be present when working with discrete environmental sampling data. Given that this error is always present, where does that leave you for drawing conclusions with discrete environmental sampling data? Short of collecting an infinite number of samples, what can you do to estimate reasonable exposures for your health assessment? You can use information from the samples that were collected to draw inferences about the larger area from which those samples were drawn. As I just demonstrated, if you were to simply use the sample average to do so, you may over or underestimate true mean exposures. One way to get around this is to estimate a range that contains the true mean with some defined rate of error or level of confidence. This is called a confidence interval. Remember that our original estimate of 25 ppb for the 10 surface soil samples collected in the soccer field represents the average concentration for those 10 samples, and not the actual or true mean concentration for all surface soil in the field. In this case, a confidence interval would tell us the range within which we expect the true mean herb concentration to lie. The confidence level is commonly set at 95%. In the case of the 95% confidence level, the upper and lower limits define the range that will contain the true mean 95% of the time. Another way to think of this is that if you were to go out and collect samples repeatedly in the same area or exposure unit, the true mean would fall within the upper and lower limits of the confidence interval in 95% of those resampling efforts. As an example, let's go back to the soccer field with an average concentration of 25 ppb. Let's say that the 95% confidence interval was calculated with a range of 16 ppb to 35 ppb. This means that if we were to resample the field over and over again, the true mean would lie somewhere between 16 and 35 ppb 95% of the time. Therefore, 35 ppb provides a conservative and upper bound estimate of the true mean. If the range was wider, we would have less confidence in the results. If the range was narrower, we would have more confidence in the results. In fact, the width of the 95% confidence interval depends on the number of samples and the variability of sampling results. And this is related to the data distribution. Environmental contamination varies over geographic space and through time. It is rarely constant. You can use the distribution of measured concentrations, though, to help characterize this variability. Data distributions illustrate how data are dispersed or concentrated around specific values or within ranges. Data distributions can assume various shapes, several of which are well defined. Common distributions observed in environmental data include normal, log normal, or gamma distributions. Some statistics are based on the data distribution. While visual examination can be used to help understand the shape, statistical tests can also be used to identify the best fitting distribution for a specific data set. The EPC guidance mentions several such tests. providing detailed instructions on how to use them and interpret the results. As an example, on this slide, I'm presenting plots of the normal and log normal distributions. These plots show the distribution of sampling results. They depict all possible values in a dataset and their respective frequencies. Contaminant concentrations are on the horizontal x-axis, ranging from lower concentrations on the left to higher concentrations on the right. The frequency of results at these concentrations is shown on the vertical y-axis, with lower frequencies at the bottom and higher frequencies at the top. The graph on the left illustrates a normal distribution, characterized by its classic symmetric or bell-shaped curve. Most observations are concentrated around a central value, with extreme high and low values occurring equally frequently. The graph on the right displays a log normal distribution, characterized by its asymmetric shape. There are many results at lower concentrations and relatively few at higher concentrations. This distribution is described as right skewed due to its longer right tail and is commonly exhibited by environmental data. To further illustrate the concept of data distributions, I will now quickly show you how an environmental data set fits into a distribution. On the left side of this slide, I am showing a table of analytical results for 18 soil samples. For example, sample 1 was reported at a concentration of 1.3 milligrams per kilogram, and sample 18 was reported at a concentration of 1.5 milligrams per kilogram. The figure on the right shows how these data are plotted on a histogram. Contaminant concentrations are displayed on the x-axis, divided into 5 different ranges or bins. The first bin captures results between 1 and less than 2 milligrams per kilogram. The second bin captures results between 2 and less than 3 milligrams per kilogram, and so on. The y-axis indicates the frequency of results in each bin. Returning to the first bin, it captures results between 1 and less than 2 milligrams per kilogram. 3 results in the table fall within this range: sample 1, sample 3, and sample 18. Accordingly, the histogram shows that there are 3 results within this range, or for that bin. The same method is applied to the other bins, producing a graphical representation of the data distribution. In this case, the histogram displays a symmetric distribution, with most results clustered around a central value and equally common extreme and high-low values. Therefore, the data set appears to fit to a normal distribution. Now that you've seen what distributions look like, let's discuss some underlying principles and the insights that they offer. 2 primary parameters define the common distributions of normal, log normal, or gamma found in environmental data: the center or mean and the spread or standard deviation. The mean is calculated as the sum of all measurements divided by the number of values in the dataset. In a normal distribution, the mean is also the median and the most frequently observed value. The standard deviation measures variability around the mean, indicating how spread out the data are. This slide displays 2 images that approximate a normal distribution with similar means. The left image has a broader curve, suggesting a wider spread of results around the mean or a larger standard deviation. Conversely, the right image shows less variability or a smaller standard deviation, with a greater percentage of results within a narrow range and fewer extreme high and low values. Importantly, the distribution of a dataset can be used to estimate various statistics, including confidence limits around a mean. As I mentioned before, we can calculate the mean contaminant concentration for samples that we collect in the field. However, we know means from discrete sampling programs may under or overestimate the true mean. Using data distributions, we could instead calculate the range within which we expect the true mean to lie. As you've already learned, This is called a confidence interval around a mean, with the lower and upper values of this interval being called the confidence limits. Precision in this range is based on the width of the interval. Related to this point, confidence intervals depend on two parameters: the number of samples in a data set and the variability in measurements among those samples. I'll use the image of the normal distribution on the right side of the screen to illustrate this. Imagine that the dashed line going through the center of that distribution represents the average, and that the two lines to either side of that represent the upper and lower 95% confidence limits for the true average of the 10 samples collected in the soccer field example. The placement of these bars is influenced by the sample size and by the variability in measured concentrations. Let's start with sample size. If we were to collect 40 samples instead, we would expect the confidence interval to narrow, indicating a smaller range within which the true average lies. As a result, our upper and lower confidence limits would move closer to the mean. When considering variability, if we knew that the herbicide was evenly spread across the field, the variability of concentrations between samples would likely be smaller, resulting in a smaller standard deviation and a narrower confidence interval. This too would bring the upper and lower confidence limits closer to the mean. Mathematical formulas exist for generating upper and lower confidence limits around a mean, based on the best fitting data distribution. Formulas also exist for data that do not conform to a specific distribution. This introduces two fundamental concepts emphasized throughout the guidance: parametric and non-parametric statistics. Parametric statistical methods assume a specific probability distribution, such as normal, log normal, or gamma distributions. Non-parametric statistical methods do not assume a particular probability distribution. A common approach is to estimate the upper and lower 95% confidence limits around a mean. In many fields, scientists rely on the upper 95% confidence limit around the mean, or the 95 UCL, as a conservative estimate of the mean. So what are 95 UCLs? A 95 UCL represents a value that equals or exceeds the true average of a distribution 95% of the time. This means that a 95 UCL has a very low likelihood, specifically a 5% chance, of underestimating the true average of a distribution. A 95 UCL can be interpreted as a probability statement. That is to say, I am 95% confident that the true distribution of the sampling data has a mean less than or equal to my calculated 95 UCL. In the context of environmental data sets and the public health assessment process, the 95 UCL offers a health protective estimate of the true average concentration within an exposure unit and helps minimize the risk of underestimating exposures. To further emphasize this point, let's revisit the soccer field example. This slide displays 6 images of the same soccer field, each with a different arrangement of 10 samples. The average concentrations are shown beneath each graphic and vary by a fair amount. This variation is expected due to the limited sample size. Let's imagine, even though it's unrealistic and seemingly impossible, that someone went out and scraped off the top few inches of soil throughout the entire soccer field and could thereby measure the true mean contaminant concentration. Let's say that the true mean was 250 ppb. The lowest average shown here is 100 ppb. If that happened to be the arrangement of sample locations, you would underestimate exposures. The highest average is 850 ppb. If that happened to be the arrangement of sample locations, you would overestimate exposures. What should you do? Well, you can use 95 UCLs to take luck out of the picture. This slide displays sample location configurations for 3 soccer fields, along with their respective average and 95 UCL values. I'm only showing 3 configurations here to keep it simple. In all 3 cases, the 95 UCL exceeds the corresponding calculated average from the samples in the field, as expected. But how do those 95 UCLs compare to the true average, which we're pretending is known to equal 250 ppb? The soccer field on the left has a 95 UCL of 450 ppb. This value is greater than the presumed true average of 250 ppb. In fact, all of the 95 UCLs on this slide are higher than that true average value. By definition, we would expect this to occur 95% of the time. Remember, the 95 UCL equals or exceeds the true average of a distribution 95% of the time. Hopefully, this emphasizes the point that despite variability in contamination levels and the uncertainty associated with estimating averages from a limited number of samples, 95 UCLs provide confidence that you're not likely underestimating true exposures. In summary, average contaminant concentrations are often the best metric for characterizing exposures within an exposure unit. However, true average concentrations are never known. 95 UCLs offer a health protective estimate of average concentrations within an exposure unit, essentially providing an upper bound estimate of the true average. And 95 UCLs account for the number of samples, the number of non-detects, and the variability in contaminant concentrations observed in a set of sampling results. Now that you have a better understanding of EPCs and the statistical concepts associated with them, I'm going to step through ATSDR's recommended approach for selecting the appropriate EPC statistic for a given scenario. As I mentioned earlier, EPCs are represented by two different statistics: 95 UCLs as conservative estimates of the mean, or maximum detected concentrations. In general, characteristics of the dataset determine the appropriate statistic. This includes things like the number of samples and the frequency of detected results. Exposure duration also can sometimes determine the appropriate statistic. When evaluating chronic and intermediate exposures, health assessors largely rely on the characteristics of the dataset. When evaluating acute exposures, however, health assessors need to consider several other factors before deciding whether to use a 95 UCL or maximal value. We'll start with how to select EPC statistics for chronic and intermediate exposures. To reiterate from the previous slide, EPCs can be 95 UCLs or maximum detected concentrations. For exposures of these durations, health assessors must review the number of samples and the frequency of detected results to determine the appropriate statistic for their public health assessment. Specifically, health assessors should use 95 UCLs for data sets that have 8 to 19 samples and 4 or more results above the detection limit, or that have 20 or more samples with greater than 20% of results above the detection limit. Health assessors should use the maximum detected concentration for data sets that have 7 or fewer samples, 8 to 19 samples, but with 3 or fewer detected results, or 20 or more samples, but with less than 20% detected results. ATSDR's EPC guidance for discrete sampling provides additional detail on these selection criteria. And good news is that ATSDR has developed a web-based calculator tool called the EPC tool, which applies these selection criteria to a data set and then automatically calculates the appropriate EPC. I will tell you more about this in just a bit. Now let's talk about some of the exceptions in selecting EPCs for acute exposures. Just the same as chronic and intermediate exposures, EPCs for acute exposures can either be 95 UCLs or maximum detected concentrations. Specific to acute exposures, however, the toxicity of a given contaminant sometimes drives the appropriate statistic. And while toxicity can be an important factor when determining the EPC statistic, there are several other considerations. These include temporal variability in the environmental data, patterns in human activity, and the influence of atypical conditions, such as reporting errors and false positive detections of common laboratory contaminants, such as methylene chloride. It's important to note here that health assessors must rely on their professional judgment when selecting appropriate EPC statistics for evaluating acute exposures. Over the next few slides, I'm going to walk through different considerations when doing so, but please know that these are not necessarily rules that must be followed, but rather factors that should be carefully reviewed on a case-by-case basis. As I just mentioned, health assessors should consider available toxicity data as one of the key factors when selecting EPC statistics for acute exposures. Specifically, they should evaluate the exposure duration used in the human or animal study that forms the basis of the toxicity value that will be used in the health evaluation, such as an ATSDR acute minimal risk level, or MRL. When the acute MRL, or comparable toxicity value, is based on a human or animal study that evaluated a short duration, exposure duration, health assessors should use the maximum concentration. A short duration could be considered one ranging anywhere from 1 to 3 days. When the acute MRL, or comparable toxicity value, is based on a study with exposures lasting 4 or more days, health assessors should use the 95 UCL. The idea here is that the acute EPC for a given contaminant should match the window of exposure used in the applicable toxicity study. Now, although exposure duration of the underlying study is a key consideration, there are several exceptions to this. For example, one exception is related to inhalation studies that are not adjusted to a daily exposure. Basically, some chemicals exist where the inhalation MRL is based on an exposure concentration that was not adjusted from an intermittent exposure to a continuous 24-hour concentration. Most of these chemicals cause irritant or poor contact effects from brief exposures. This includes acrolein, ammonia, 2-butanone, formaldehyde, hydrogen sulfide, and sulfur dioxide. For these, you should use the maximum concentration to evaluate acute exposures, regardless of the other criteria that we just discussed. More information about this topic can be found in the Vast Resources page in a document about exceptions to exposure factor adjustments. As an example, imagine a case where a health assessor needs to assess acute oral ingestion exposures for chlordane. This chemical has an ATSDR acute MRL for oral ingestion. To identify the exposure duration for the underlying toxicity data, the health assessor needs to look at ATSDR's toxicological profile for chlordane to see how the acute MRL was derived. This slide presents a screenshot of Appendix A from that profile, published in February of 2018. As described in the summary on this MRL worksheet, the acute ingestion MRL was derived from effects observed in mice exposed to chlordane for 7 days. Given this, the health assessor should use the 95 UCL to evaluate acute ingestion exposures to this chemical, assuming other criteria are met. Remember that if the underlying toxicity study involved a longer exposure duration, you should use the 95 UCL. As another example, consider a scenario where residents have expressed concern about exposures to methyl tert butyl ether, or MTBE, while showering due to groundwater contamination from an underground storage tank. MTBE can cause harm after just a few hours of exposure at high levels, which is the basis of ATSDR's acute inhalation MRL. To determine the appropriate EPC statistic for evaluating acute inhalation exposures, the health assessor needs to identify the underlying toxicity study for that MRL. This slide presents a screenshot of Appendix A from ATSDR's toxicological profile for MTBE, published in September of 2023. As described in the summary on this MRL worksheet, the acute inhalation MRL was derived from a study on female rats exposed once for 6 hours a day. That is also shown in Table A1 from the tox profile. Given this, the health assessor should use the maximum detected concentration as the EPC, rather than the 95 UCL. Remember that if the underlying toxicity study involved a shorter exposure duration on the order of 1 to 3 days, you should use the maximum concentration as the EPC. Earlier in this presentation, I mentioned that there are several exceptions to relying solely on toxicity information. One of these pertains to the temporal variability in environmental data, or how data collected repeatedly over time may vary. Generally, when sampling over longer time frames, the maximum concentration is preferred as the EPC statistic for acute exposures, regardless of whether the relevant toxicity information value is based on exposures lasting more than 3 days. Applying this approach acknowledges variability in temporal data and helps ensure that shorter-term high exposures are accounted for. Imagine a series of indoor air samples collected monthly at a residence over a 1-year period, aimed at evaluating vapor intrusion issues related to a contaminant with an acute MRL derived from a 1-week exposure study. The results are shown on this slide. The maximum is reported at a value of 44 ppm, and the 95 UCL is 32 ppm. What is the most appropriate EPC to use? The 1-week exposure window from the underlying toxicity study suggests the use of the 95 UCL. However, considering the temporal variability in sample results, it's possible that someone might be exposed to the maximum detected concentration over a shorter acute duration. Therefore, in this case, the health assessor should use the maximum concentration, regardless of the underlying toxicity data, because there are not enough samples within a single 2-week period to calculate a 95 UCL. Later in this presentation, I will introduce some reality checks for calculated EPCs. These checks include comparing maximum concentrations to corresponding 95 UCLs. In cases where the 95 UCL exceeds the maximum concentration, it may be more appropriate to use the 95 UCL. Another exception relates to human activity patterns. In some cases, we may opt to use the maximum value to account for specific human activity over the acute exposure duration, even if a review of the underlying toxicity data suggests that using the 95 UCL would be more appropriate. This point is best illustrated through an example. Imagine a scenario where there is concern about soil pica exposures at a residence where children are consuming soil. 10 surface soil samples were collected throughout the residential yard and analyzed for a pesticide with an acute MRL based on a 5-day study. While a review of the toxicity data suggests that the 95 UCL is the most appropriate measure, the highly acute nature of this exposure means it is possible for a child to be repeatedly exposed to the maximum concentration if they play in the most contaminated part of the yard throughout the week. Therefore, the health assessor should use the maximum concentration as the EPC. Other considerations relate to atypical conditions and data quality. These are especially important when the maximum value is selected as the EPC. Health assessors need to be sure that the maximum value in the dataset adequately represents environmental conditions within the exposure unit. One consideration is the potential influence of uncharacteristic or exceptional events on the dataset. For example, consider the effect of a nearby wildfire reported to be burning on the day an ambient air sample was collected for analysis of particulate matter tied to an industrial facility. In instances like this, health assessors should use the highest concentration that is not likely affected by such events to represent site conditions. Another consideration involves issues tied to data quality, such as the impact of analytical artifacts due to blank contamination or a data point that is presented in the wrong units. Any suspected anomalies in the data should be carefully reviewed before using the maximum detected value as the acute EPC. In summary, health assessors should use the maximum detected value, or the 95 UCL, as the EPC for acute exposures. To determine which one to use, first review the study duration and the underlying toxicity data. Use the maximum concentration if the study is based on short exposures of 1 to 3 days, and the 95 UCL if the study assesses exposures over a longer time period. If you select the 95 UCL, ensure that you have sufficient data to calculate this statistic. Additionally, it's important to remember that determining the appropriate EPC statistic for acute exposures requires professional judgment. As I just demonstrated, there are exceptions to these criteria that should be considered on a case-by-case basis. Now that you have learned how to select the appropriate EPC statistic, let's go through the process of calculating a 95 UCL when it's deemed appropriate. Following ATSDR's EPC guidance, the general strategy for calculating 95 UCLs begins with determining that the available environmental data are appropriate for doing so. Health assessors need to be sure that there are enough samples, and more importantly, enough detected results to calculate a reliable 95 UCL. Specifically, 95 UCLs can be calculated for datasets with 8 to 19 samples with 4 or more results above the detection limit, or 20 or more samples with greater than 20% of results above the detection limit. The next step is to choose a tool for calculating 95 UCLs. ATSDR recommends using its web-based EPC tool, which not only computes the 95 UCL based on characteristics of the sample distribution, but also assesses the appropriateness of this statistic and conducts all required reality checks, as outlined in the EPC guidance. If the maximum concentration is more appropriate, the EPC tool will provide that value instead. Moreover, the EPC tool generates EPCs for multiple exposure units and contaminants in a format that can be easily imported into FAST. I'll demonstrate this tool and provide relevant resources later in this presentation. ATSDR's EPC guidance also includes detailed instructions on calculating 95 UCLs using a publicly available software program developed by EPA called ProUCL, as well as the programming language R. These tools can effectively manage non-detect observations in accordance with ATSDR's preferred computational methods for EPCs, but they do not automatically apply ATSDR's criteria for selecting the maximum concentration or the appropriate 95 UCL. The guidance features decision trees or flowcharts that outline manual steps for calculating 95 UCLs across various dataset types using both tools. However, due to the manual process involved, ATSDR strongly encourages health assessors to use its EPC tool, which again automates the calculations following the EPC guidance. The process for calculating 95 UCLs can be broken down into 3 key steps. First, health assessors review and process the data for a specific exposure unit. If using the EPC tool, they enter their data into the EPC tool Excel template. Second, they calculate 95 UCLs for that exposure unit, preferably with ATSDR's EPC tool. And third, they perform reality checks on the results to ensure that they're suitable for use in the health evaluation. And as I mentioned before, ATSDR's EPC tool will automatically calculate the appropriate EPC for a data set, whether that be the 95 UCL or the maximum concentration, and then we'll run those reality checks. To begin, I'll walk through that first step of processing the data. This requires 3 main activities. Health assessors perform a data quality review. They identify and process duplicate and replicate sample results, and then they identify and process non-detect observations. Let's go through these in detail. The first step to performing a data quality review is to ensure that the environmental data are of known and high quality and meet the data quality objectives for the health evaluation. Next is to review the data for rejected results, usually marked with an R qualifier. These results are unusable due to significant deficiencies in laboratory analysis or quality control. health assessors should remove these results from their dataset before calculating 95 UCLs, and then note this limitation in their health assessment or report. Finally, health assessors should review any estimated values in their dataset, which are typically flagged by a J qualifier. These values can arise when laboratory equipment quantifies a chemical concentration below the minimum required reporting limit. Health assessors should treat such data as valid sampling results and label them as detected values. Importantly, though, they should be aware that datasets with many J-qualified results can increase uncertainty in 95 UCL calculations, which should be noted in their health assessment or report. Another step when processing the data is to identify and process duplicate and replicate sample results. Duplicate results come from two environmental samples collected in the field from the same point in time and space. Replicate results come from a single environmental sample that was analyzed twice by a laboratory. When these types of samples are in a data set, health assessors should combine the results to obtain a single value for the duplicate or replicate pair. This ensures that the sample is not double counted in 95 UCL calculations. Here's some general guidelines to follow in selecting the appropriate concentration. For duplicate and replicate samples with two different detected values, ATSDR recommends using the average or maximum concentration. When the detected results are similar, ATSDR recommends using the average of the two samples. When the detected results are sufficiently different based on your professional judgment, ATSDR recommends choosing the higher value to be more health protective. Health assessors may wish to review the data quality report or contact a chemist to gain insight into why the samples have significantly different concentrations when this occurs. If a contaminant is detected in one sample of the pair and not the other, use the detected value. If both results are non-detect, keep the results as such and include the higher detection limit. This slide demonstrates how to process duplicate sampling results for a hypothetical set of surface soil samples. The table on the left shows laboratory results for 3 surface soil samples: Sample 1, a duplicate of Sample 1, and Sample 2. To process these data for EPC calculations, the health assessor needs to obtain a single result for the duplicate pair. Retaining both duplicate results in the dataset may bias the 95 UCL towards that sampling location. Given the similarity between results for the duplicate pair, 0.7 milligrams per kilogram for the parent sample and 0.68 milligrams per kilogram for the duplicate, the health assessor should average them to yield a single value. The table on the right shows the data for EPC calculations, where sample 1 is now the averaged value of 0.72 milligrams per kilogram. The purpose of this exercise is to prevent artificial bias in 95 UCLs for sampling events involving duplicate samples or replicate analyses. This approach ensures that each scheduled sampling event or location is only represented once in EPC calculations. Another step is to identify and process non-detect observations so that the tool you are using to calculate EPCs knows whether each result is a detected value or not. This step is crucial, as ATSDR has established preferred statistical methods for 95 UCL calculations based on the occurrence and frequency of non-detects. These methods are integrated in the EPC tool and detailed in the EPC guidance document. This slide presents an example for how to do this. The table on the left displays the original laboratory results for 5 surface soil samples, reported in milligrams per kilogram. Samples 1 and 3 are non-detect observations marked by a U qualifier. U qualified data indicate that the sample was not detected above the instrument detection limit. Sample 1 has a detection limit of 0.1 milligrams per kilogram, while sample 3 has a detection limit of 0.2 milligrams per kilogram. Sample 5 is an estimated value, as indicated by the J qualifier. J qualified data generally indicate that the reported concentration is an estimated value. To calculate 95 UCLs using any of the tools mentioned in this webinar, health assessors must create a new column and populate it with zeros and ones to indicate whether each result is a detected value or not. The table on the right illustrates how that would be done. The first column lists the sample IDs. The second column presents concentrations without the qualifiers, and the third column contains zeros and ones to indicate detected values. Zeros are entered for samples 1 and 3 to denote non-detect observations, while ones are used for the other samples, which the various tools will interpret as detected values. The J-qualified result from sample 5 is carried through as a detected value, just the same as the other detected results. Once the data have been reviewed and processed, health assessors can calculate EPCs. ATSDR has preferred statistical methods for doing so, which vary depending on the number of samples in a dataset. For smaller datasets with 8 to 19 samples, ATSDR recommends parametric statistics. For larger datasets with 20 or more samples, ATSDR recommends using non-parametric or distribution-free statistical methods. Additionally, ATSDR has identified preferred parametric and non-parametric 95 UCL statistics based on other characteristics of the dataset. For small datasets, ATSDR recommends different parametric statistical methods based on the distribution and presence of non-detect observations. For larger datasets, ATSDR recommends different non-parametric statistical methods considering the presence of non-detect observations and whether those non-detects share the same detection limit. For more details on this topic, review ATSDR's EPC guidance. I mentioned earlier that there are several tools that can be used to calculate 95 UCLs. ATSDR's EPC tool automatically identifies the appropriate statistical method to use when calculating 95 UCLs based on the criteria outlined in the guidance, and then automatically calculates the appropriate 95 UCL using that method. Additionally, if the maximum detected concentration is more appropriate than the 95 UCL, the EPC tool will return that value instead. ATSDR's EPC guidance details the manual process for determining the appropriate statistic if health assessors use EPA's ProUCL software or the R programming language. With both tools, the user must assess the data distribution manually and then select or request the approach for calculating the 95 UCL based on that information and other dataset characteristics. Due to the manual nature of these tools, ATSDR recommends that health assessors use the EPC tool. To illustrate the manual process involved when calculating 95 UCLs with ProUCL or R, I've included a screenshot of one of the related decision trees or flowcharts from the EPC guidance on this slide. This particular flowchart outlines the decision logic for selecting appropriate 95 UCL statistics when using ProUCL for datasets with at least 8 samples and with non-detect observations. The guidance includes similar flowcharts for other scenarios and for the R programming language. While I won't go through each step in detail, I've included this figure here simply to give an example of the manual steps that would be required to calculate a 95 UCL using ProUCL or R for each unique combination of exposure unit and contaminant in your data set. Health assessors can now use ATSDR's EPC tool as an alternate approach. In fact, ATSDR recommends that health assessors do so. The EPC tool is an R-Shiny web-based application designed to calculate EPCs with discrete sampling data. It automatically implements all of the EPC decision logic in 3 ATSDR guidance documents. This includes the EPC guidance for discrete sampling, which is the focus of this webinar, as well as 2 chemical-specific documents on calculating EPCs. Those are ATSDR's guidance for calculating benzoate-pyrene equivalents for cancer evaluations of PAHs, and ATSDR's toxic equivalence guidance for dioxin and dioxin-like compounds. Additionally, the EPC tool offers the added benefit of outputting EPCs in a format that can be readily imported into FAST. This tool was designed for and is available to ATSDR and AppleTree health assessors. AppleTree is ATSDR's cooperative agreement program with state health departments to conduct health assessments at hazardous waste sites. The acronym stands for ATSDR's Partnership to Promote Local Efforts to Reduce Environmental Exposure. ATSDR's EPC tool can be accessed through CDC's Secure Access Management Portal and through the FAST Resources page. Additional information can be found in the EPC Tool User's Guide and the EPC Tool Training video, which are also available in the FAST Resources page. If you have additional questions about the EPC tool that are not covered by these resources or about gaining access, please email fast@cdc.gov for assistance. For any emails that you send to the FAST address, please include ATSDR EPC tool in the subject line so that the FAST team knows your message is about the EPC tool. Moving on, and as a final step, health assessors should perform several reality checks on the calculated values to ensure they are appropriate for use in a health assessment. This includes comparing 95 UCLs to average concentrations, comparing 95 UCLs to maximum concentrations, checking for the influence of outliers, and having a colleague check your work. Of note, ATSDR's EPC tool runs the first two reality checks automatically. I will briefly step through each of these checks now and later demonstrate how to implement them through a case study example. I'll begin with comparing 95 UCLs to average concentrations. Health assessors should first compare the 95 UCL to the corresponding average to ensure that the 95 UCL exceeds the average. This should always be the case. If it does not, there is likely a computational error that needs correction. Health assessors should then compare the 95 UCL to a value equal to 3 times the average. If the 95 UCL is 3 times greater, the health assessor should determine if data outliers are strongly influencing the results, if there are not enough samples to support a precise estimate, or if some other type of sampling analysis or computational error may have occurred. Health assessors will need to review these instances on a case-by-case basis to determine the best course of action. Section 3.7 of ATSDR's EPC guidance for discrete sampling provides additional information and direction on this point. As another reality check, health assessors should compare 95 UCLs to maximum detected concentrations. Please note that for small and highly variable data sets, it's not uncommon for 95 UCLs to exceed maximum data points. Even so, a 95 UCL above the maximum detected concentration could be a sign of a computational error. Health assessors should check this as a first step. If the 95 UCL was calculated correctly and indeed exceeds the maximum concentration, health assessors should select the appropriate EPC statistic based on the number of samples included in the dataset, along with their personal judgment. When the 95 UCL exceeds the maximum concentration for a small dataset with 8 to 19 samples, ATSDR recommends using the 95 UCL as the EPC. In such cases where data are limited, the maximum concentration may underestimate the true mean of contaminant concentrations in the exposure unit. For larger data sets with 20 or more samples, a 95 UCL exceeding the maximum detected concentration is unexpected. This suggests a high degree of variability in the sample results or insufficient data to support a reliable 95 UCL concentration. In these cases, ATSDR recommends using the maximum concentration as the EPC, provided it is assumed to represent the higher end of the distribution of actual contaminant levels and therefore reflects worst-case exposures. The logic outlined here, again, is automatically implemented when calculating EPCs with ATSDR's EPC tool. In some cases, it may be necessary to check for the influence of outliers, especially when a 95 UCL exceeds 3 times the average concentration. When this occurs, health assessors should consider conducting a sensitivity analysis to better understand how one or more high values affects the 95 UCLs. This involves recalculating the 95 UCL after excluding the unusually high value and then comparing it to the original 95 UCL. As an example, the table on this slide displays results for 10 soil samples in milligrams per kilogram. Sample 10 stands out from the rest of the data set with a reported value of 16 milligrams per kilogram, 20 times higher than the next highest value. A health assessor calculated the 95 UCL for the 10 samples and obtained a result of 7.4 milligrams per kilogram. This value is more than 3 times the corresponding average of 2 milligrams per kilogram, so the health assessor decides to conduct a sensitivity analysis. They go back and recalculate the 95 UCL, this time excluding sample 10. This results in a 95 UCL of 1.0 micrograms per kilogram. This 95 UCL is considerably lower and a good indication that the health assessor should go back and carefully review their data to ensure the outlier is a valid result. The outlier in this data set should only be excluded if the health assessor can justify the exclusion based on their data quality review. In most cases, particularly for large data sets, 95 UCL should be relatively unaffected by the removal of 1 or 2 data points, even those at the higher end of the distribution. However, some 95 UCLs may be highly sensitive to the presence of data outliers. This is important if an exposure dose calculated from a 95 UCL exceeds a health guideline value when all of the measurements are included, but falls below when the outliers are removed. Such cases may require closer review of the data and additional sampling to ensure the exposure use contamination is adequately characterized. As a final step, health assessors should always try to have a colleague check their work. If everything is verified, they should feel confident using the calculated values as EPCs in their health evaluation. In summary, EPC statistics are 95 UCLs or maximum concentrations. Selection criteria can vary for acute and intermediate or chronic exposures. Where necessary and appropriate, health assessors should acknowledge any limitations of the selected EPC and recommend additional sampling. And ATSDR's EPC tool streamlines and automates the agency's preferred computational procedures for selecting and calculating EPCs. Now that we've covered the guidance, I'll walk through a case study example using a hypothetical data set to demonstrate the entire process. For this case study, I will use ATSDR's EPC tool. I'll begin with some site background. In this example, a community is concerned about exposure to various metals that have been detected in groundwater. The source of pollution has been identified as a nearby industrial site. A state agency has collected monthly samples from several public water supply wells, each of which serves a different area of the community. In this community, water is not blended across multiple wells. Each well serves a different group of homes. With this information, we can define the exposure groups for receptors, exposure pathway, exposure unit, and exposure duration. This is an important step since EPCs are calculated for each unique combination of these parameters. In this example, there is concern about exposures among child and adult residents. Children of different ages and adults therefore make up the exposure groups. Residents are concerned about contaminated drinking water. Let's assume that the health assessor has already identified drinking water ingestion as a completed exposure pathway. As a reminder, we're considering a hypothetical site, and for the sake of time, I'm only going to discuss this one exposure pathway. If you were conducting a public health assessment, you would need to consider all potential and completed exposure pathways. As I previously mentioned, there are several public water supplies in this community, and each well serves a different part of the community. Since water is not blended across multiple wells, each public water supply well is defined as a unique exposure unit. For the purposes of this presentation, I'll focus on just one of those exposure units, identified as Exposure Unit 1 or EU1. In this example, a health assessor would need to consider chronic, intermediate, and acute exposures. But for the purposes of this presentation today, we'll focus on chronic exposures. Let's assume that a health assessor has compared maximum detected concentrations of the metals to their corresponding ATSDR comparison values and identified arsenic as the only contaminant of concern. This means that the health assessor now needs to estimate an EPC to further evaluate chronic exposures to arsenic for residents consuming water from EU1. The table on this slide presents results in units of micrograms per liter for samples collected from that public water supply well. The health assessor will use these data to calculate an EPC. Before we continue, I'll point out some key characteristics of the dataset that are relevant to these calculations. First, the dataset contains results from 16 samples. Second, the dataset includes several non-detect observations identified by the U flags or qualifiers next to the reported values. There are 6 non-detect results, each with the same detection limit of 4.0 micrograms per liter. Third, the dataset contains one result that is reported as an estimated value, as indicated by the J flag. Specifically, sample 3 is reported at a concentration of 3.8 micrograms per liter, but the J flag warns us that there's some uncertainty around that measurement. And lastly, the dataset contains one duplicate result. The state agency collected sample 7 dupe as a field duplicate of sample 7. All of this information is critical when entering the data into the EPC template and determining the appropriate EPC statistic. What is the appropriate EPC statistic? Remember that for intermediate or chronic exposures, EPCs are either the 95 UCL or the maximum detected concentration. 95 UCLs are used for data sets that have 8 to 19 samples and 4 or more results above the detection limit, or 20 or more samples with greater than 20% results above the detection limit. As I just went through, this data set contains 16 samples and 10 detected values. Because of this, the health assessor knows that the 95 UCL is the appropriate EPC statistic. Before the health assessor can calculate a 95 UCL, they need to carefully review and process the data. First, the health assessor must perform a data quality review. For the purposes of this example, let's assume that the data are of known and high quality and have been determined to be representative of actual exposure concentrations. Next, the health assessor needs to process duplicate results. In this data set, there is one duplicate sample pair, which includes sample 7 and sample 7 dupe. Arsenic was detected at a concentration of 7.4 micrograms per liter in sample 7 and at a concentration of 6.8 micrograms per liter in the corresponding duplicate. Since both values have detected results and are similar, the health assessor should average the results to obtain a single value for the duplicate pair. In this case, the health assessor calculates an average of 7.1 micrograms per liter, replaces the original sample 7 result with this average, and then deletes sample 7 dupe from the dataset. The next step is to process the detect and non-detect observations. This is necessary so that the EPC tool knows whether a given result is a detected value or not. Using the EPC tool template, the health assessor needs to assign each sample result a 0 or 1 value. They assign a 0 to non-detect observations and a 1 to detected values. This slide shows what that looks like. The table on the left side of the screen shows the original results, while the table on the right shows how the data are prepared or processed for calculating EPCs. For example, sample 1 was reported at 4.0 micrograms per liter and flagged as a non-detect observation with a U qualifier. For calculating the EPC, the health assessor removes the U qualifier from the result field and assigns a 0 value to indicate that this is a non-detect. Sample 2 was reported at a detected concentration of 4.9 micrograms per liter. For calculating the EPC, the health assessor assigns a 1 value to indicate that this is a detect. Sample 3 was reported at a detected concentration of 3.8 micrograms per liter, but with a J flag to indicate that it is an estimated value. In this case, the health assessor removes the J flag if it's in the same field as the sample result and assigns a 1 value to indicate a detect. Now that the data are processed, the health assessor can calculate the EPC. On this slide, I'm showing the EPC data import template from ATSDR's EPC tool, populated for this dataset. You can download the template from the EPC tool website. Be sure to enter the data according to the column headers on the Raw Data tab. The first column is the exposure unit, and for this case study, is populated with EU to indicate the exposure unit for each of the 16 samples. The exposure unit name has to be the same for each of these 16 sample results. The next 2 columns indicate the contaminant name, arsenic, and the corresponding CAS-RN or CAS number. The contaminant name has to be the same for each entry and is case sensitive between entries. The column that follows is for the sample media, which in this case is water and is chosen from a drop-down menu. The 5th column is populated with the sample results and only contains numeric characters. All qualifiers have been removed. The 6th column contains units, micrograms per liter, and the 7th column contains the 0 and 1 detect, non-detect designations that I just stepped through. The last column contains the unique sample ID for each result. As I've mentioned, you can't change the header name for these 8 columns, but you can add a notes field after the sample ID. The EPC data template does have a README tab that provides an explanation and notes for each of these fields. Once these data have been entered into the template and the file is saved and closed, the health assessor loads the template into ATSDR's EPC tool. On this slide, I'm showing you a screenshot of that web-based tool. Specifically, I'm showing the data import screen, which is also the first screen you see upon launching the tool. Below the introductory text is a link to download the data import template, as well as a place to upload a populated or completed data template. Upon clicking Browse, a pop-up window will appear, which the health assessor uses to search for and select a saved copy of their populated data import template. Once the template is loaded, a data import summary will appear at the bottom of the page, as shown in the screenshot on this slide. The health assessor reviews the information here as a check to be sure that the correct number of EPCs will be calculated. In this case, there are 16 samples, and those samples are from a single exposure unit for a single contaminant and for a single medium. As expected, the tool will return 1 calculated EPC. Since that is what is expected for this dataset, the health assessor clicks Calculate EPC. On this slide, I'm showing you a screenshot of the results summary page. There is only 1 row of results here because the health assessor is calculating a single EPC. This summary shows that the tool calculated an EPC of 5.636 micrograms per liter for arsenic in water for exposure unit 1. The summary also tells us that this EPC is based on a 95 UCL, as expected, because the dataset contains between 8 and 19 samples and has 4 or more results above the detection limit. Importantly, there are no quality control flags, R warnings, or error flags for this calculated EPC. If the health assessor clicks the Download Fast Import Data option at the bottom of the screen, they can download an Excel CSV file containing the EPC data, which can then be loaded directly into FAST. If they click the Details option on the lower right side of the screen, they'll be able to see more statistics and plots describing the data. I'll show what that looks like now. This slide presents a screenshot of the Details page. The main results section presents the same information as the Results Summary tab. Additional statistics and plots are presented below. The summary shows that there are 16 observations in the dataset, 10 of which are detected results. The 95 UCL is 5.6 micrograms per liter. The maximum detected concentration is 8.2 micrograms per liter, and the mean is 5.0 micrograms per liter. The data set best fit to a log normal distribution, which is confirmed by the shape of the data distribution shown in the histogram. These statistics and plots provide additional context for understanding the data set and the calculated EPC. The next step is to perform a series of quality control checks to confirm that the calculated EPC, or 95 UCL in this example, is appropriate to use. ATSDR's EPC tool runs these checks automatically. If the calculated EPC fails any of the checks, a quality control flag appears on the results summary page. In this case study example, the health assessor didn't see any flags in the EPC tool, but let's manually check to be sure. The table on this slide shows the same statistics that I just stepped through. The health assessor first compares the 95 UCL to the maximum detected concentration. The 95 UCL of 5.6 micrograms per liter is less than the maximum detected concentration of 8.2 micrograms per liter, and no further review is needed. So far, the 95 UCL is appropriate to use. Next, the health assessor compares the 95 UCL to the mean. The 95 UCL of 5.6 micrograms per liter is greater than the mean of 5.0 micrograms per liter, as it should be. The value passes the first part of the check. Additionally, the 95 UCL is less than a value equal to 3 times the mean, or 15 micrograms per liter. The 95 UCL is not unexpectedly higher than the corresponding average, and further scrutiny of the data is not required. The next quality control check is to evaluate the influence of potential outliers or unusually high values. Based on the comparison of the average concentration to the 95 UCL, the health assessor does not need to worry about the effect of such values. The 95 UCL being less than 3 times the average concentration suggests that there are no outliers heavily influencing the 95 UCL or skewing the results. They can skip this step. As a final quality control check, the health assessor asks a colleague to check their work. Assuming everything is confirmed during that review, the health assessor can use the calculated 95 UCL as the EPC for arsenic in their health evaluation. We've now covered all of the technical content for this webinar. Before we close, I'll provide a brief overview of what you've learned. ATSDR has developed guidance that outlines the recommended computational procedures for calculating EPCs with discrete sampling data. The overall goal of this guidance is to outline procedures for estimating exposures to ensure that health assessors use statistically robust calculations that support conclusions to protect public health. You can access a copy of the EPC guidance by navigating to the resources page on the FAGM website. We started the webinar with an overview of EPCs and the statistics that are used for calculating them. We then learned that there are two main steps when calculating EPCs. The first step is to use ATSDR criteria to select the appropriate EPC statistic, whether that be the maximum detected concentration or the 95 UCL. The second step is to use the EPC tool, which automatically incorporates ATSDR's EPC guidance to calculate the EPC tool. Throughout this webinar, I highlighted the utility of using ATSDR's EPC tool for these calculations. That tool automatically implements the EPC selection and calculation procedures that are outlined in the guidance. ATSDR encourages health assessors to use this tool whenever calculating EPCs for discrete sampling data. We also looked at exceptions, though, for evaluating acute exposures, which need to be considered outside of that tool and following ATSDR's guidance. The EPC tool is available through ATSDR's SAMS portal. To request access, please email fast@cdc.gov. Thank you for listening to this webinar. For additional information, ATSDR health assessors should reach out to the OCHA Associate Director for Science Office. Appletree health assessors should reach out to the OCDAP's Associate Director for Science Office via their technical project officers or TPOs. Thank you again.